I gather we have quite a few folks joining in so far. Spencer, are you there? It looks like most folks are muted, which works out. And then we've got the pictures off, which I think will work best. This is Joel Hanson, one of the presenters. Who's out there that can hear me?
Hey, Dr. Hanson, this is Cliff. I can hear you. I'm on board. I've just been using the chat function to welcome everybody on.
Good.
Good. In that chat function, I've asked everybody to go ahead and email Spencer that confirmation after we wrap up that you've attended, so you can get credit. I do have the share screen up and going so that we'll go through a few slides as we go through this. This is going to be a very interactive, or supposed to be interactive. So for all the extroverts out there, go ahead and chime in, ask questions, use your chat function. This is going to be pretty, low key and laxed. We're kind of in a new and interesting time right now, where the application considerations may just need extra discussion, just kind of hear and see what everybody's doing and get to hear from Dr. Hanson and myself on kind of the things that we're doing as well. I'm seeing folks that are chatting. Dr. Hanson, they're saying that they can hear you.
Good. You're coming across a little bit quiet to me.
Okay. Let me get my microphone and plug that in. Give me just a minute. Looks like we've still got people joining.
We'll give it a few minutes.
Okay, I've just plugged my microphone in. Is the sound coming across any better to you?
Yes.
Okay. We've still got some folks joining. Spencer had indicated to me that we're going to be about 75, which is the normal number, but we're at about 50 now. Looks like folks are using their chat option. Looks like it's much better with the mic, so great. I was just teaching a class this morning. I teach up at the University of Utah, and so now I know I should probably just use my mic with them too. So I guess I was interested, we'll do introductions. Just want to let you know, how this all came about. Our CEO, CMAC Kajanuri, for LTM Health had been working with Spencer to put together a CEU training. And this was before the COVID-19 stuff and then the earthquake. And so we had actually planned to do this a few weeks ago. And so I'm glad that we're able to now. I'm really grateful that CMAC and Spencer was able to kind of do some bridge work to get us kind of in front of you and share some knowledge and do some training and then have some discussions so that we can work together on some things and learn from each other. So Dr. Hanson is the medical director at Altium Health. Both of us are with Altium Health. I'm the clinical director. And the title of this CEU is Comprehensive Co-occurring Mental Health and Substance Use Disorder Treatment with, the new telehealth considerations with all that's going on. Altium Health is a addiction treatment and wellness center in Jordan Landing. Website altiumhealth.com. We've just kind of, opened doors November, December-ish. We are a full comprehensive outpatient continuum of care substance use disorder clinic. And so, you know, Dr. Hansen and I met last year at another comprehensive clinic that we've had started and developed policy and procedures for. And so now we're working together at Altium Health. Dr. Hansen, is there anything that you want to add on to that as we get started with intros?
Well, no, you've got it covered. I'm a psychiatrist. Initially practiced most of psychiatry, and then I added addiction medicine board certification about 8 years ago. I've run a couple of detox hospitals and some residential programs and outpatients, so the whole spectrum there. And it's been enjoyable working with Cliff, very knowledgeable therapist. And if you have to collaborate with somebody on complex folks like these co-occurring folks, then it's nice to have someone who you have good communication with and similar philosophies. So, and appreciate you all being here today in these circumstances. But it's nice to share the time with you.
Agreed. So we've got about 52 participants. Again, you know, go ahead and use your chat function, ask questions. Later on into the presentation, we'll get into some, you know, maybe more participation. This presentation ends at 1:30. I think it'll take us, this is, you know, co-occurring disorders, comorbidities. This topic is pretty loaded. And so, you know, potentially this becomes a part one of a two-part series just because there's so much here. But I think for today, what we want to do for the interactive learning objectives is a few things. And Dr. Hansen, I don't know do you want me to go through these, or do you want to maybe start or do this together? How do you want to kind of talk about these?
If you want to go ahead and just read through them for now, that'd be great.
Okay. So interactive learning objectives for this presentation. I think what we want to do is understand COD, that's co-occurring disorders, treatment in the current COVID-19 setting using telehealth. Second one is to maybe define terms and scope of lecture. So, you know, what do all these different terms mean? There's lots of different terms that really are saying the same thing. We've got, you know, COD, concomitant, you know, substance-induced, mental health-induced, comorbidities. You know, what we want to do is maybe understand the statistics, the challenges. There's a focus slide in here on kind of the, you know, the suicidality piece related to co-occurring disorders or comorbidity. The third bullet point, define COD and substance-induced mental health disorders, etc., and then our discussion along with that. And then be able to understand the basic challenges and solutions in treating COD patients. Understand COD issues, last bullet point, in some specific situations, such as MAT, medication-assisted treatment, in a residential setting, the polypharmacy considerations, you know, even with new emerging kinds of things happening in our community with the medical cannabis and all that kind of stuff. Dr. Hansen, I was wondering if I might take a quick poll and just maybe see and kind of gauge the audience, but also make sure that our, that our poll option is working. If I have that feature on here, doesn't look like I do actually on this Zoom account. It doesn't give me the poll option.
Hmm.
It's interesting. Teaching up at the U, I have a Zoom account with them, and then with our company, I have our Zoom account. And so one gives me the option for breakout rooms, which is great for the U, and then the other one gives me option for polling, but I don't think either account gives me both. So something to maybe think about is, what, and maybe we can use the chat function, is about, in terms of a percentage of all the patients that you're working with, 10%, 50%, 100%, if I can get maybe some participation, some interactive feedback or input, what is the percentage of patients that you're working with that you would consider to be COD, co-occurring?
And by the way, some of you may not know what the chat function is. If you look at the bottom of your screen, there's just a chat icon. Hit on that and you can type into it. And we can see what you're typing.
So we've got 95%, 90%. That's kind of what I was assuming it would be. We got a few people that have responded and participating in the chat function. Is there anything that you wanted to add into that, or on top of any of the learning objectives, Dr. Hansen?
No, I think we can probably, it's nice to get some feedback from folks on who's experiencing these kinds of patients. It is kind of unusual to not have a mix of one level or another with your patients. So it's getting to be more and more so. So no, I think we could probably start running down these one at a time with the PowerPoint.
Okay.
If you want to cover the first, let's see. Well, I think that why don't you cover? Were there some issues about telemedicine that you wanted to cover before we get into this section?
Yeah. So I think, we're in the social work profession, and maybe generally as providers out there in the industry working with, mental health crisis, substance abuse. I think we're continuing to learn day by day, ways in which our industry is affected and impacted. I think what we're learning is that, right now, probably for the next month or so, telehealth, telemental health, telebehavioral health, whatever you want to call it, is going to be necessary and required for a lot of the service delivery that we have, especially as outpatient providers. And so one of the interesting things that's come about, with HIPAA, is that there's been, some relaxed guidance. And so that means that, for the telehealth, if necessary, and as a backup, that we, in order to get people provided the necessary services, the essential services, especially, mental health, substance use, if we don't have access to, or there's technical issues restricting the use of HIPAA secure platforms like Zoom that we're using now, you can see up in the left-hand corner, there's probably a little lock that's green that means that it's all encrypted end to end, that, we have to do what's necessary. And so, using things like the iPhone, FaceTime, the Facebook Messenger, other kinds of things like that, just to get people the essential services that they need. Those previous restrictions have been not necessarily lifted, but relaxed. And so they're saying that, they're not going to be fining, organizations that have to kind of work outside of, traditional realm of or scope of practice. The other thing I think that we're learning with COVID-19 is that even with kind of easier or more flexible ways of working with folks, where there's not so much, red tape or too many barriers in place that would have normally restricted us from working with folks, the coordination of care is a little bit more relaxed too. And so when it comes to, if a patient is in, hospital setting, stepping down inpatient from inpatient psych or inpatient detox, that coordination of care can happen in a lot more streamlined kind of way without all of the, paperwork and release of information. If we need to get patients going on an outpatient, with an outpatient provider, providers like me are just, one call, one fax, one video call, one text away to make sure with all of the potential much more crisis that we're going to be seeing with this COVID stuff, that we can get people going in a streamlined fashion so that there is no, really huge or great delay or barriers to their care. So I'm really glad that, we have some of those things to kind of work around, some of those lighter parameters. And so just want to make sure that we're doing all that we can, working together with, hospitals like IHC and their emergency rooms or crisis centers or step down to, still get people into care. I think one of the things that we're learning, we run an IOP program at LTM Health, and we have been for the last several weeks, but even before that, before COVID. And we're learning that it does work still. I mean, we have patients, 8 or more in our groups almost every single day that are working through all the added anxiety and extra stress of, potential job loss or, being furloughed or, not having the support or the resources. We've only had one patient that has reported a positive diagnosis of COVID, which the health department is aware of and has been recorded. And so the telehealth has been really, what we're learning is that the telehealth has been really critical and crucial to continuing care, but is actually effective and is working, because a lot of these folks that we're working with amazingly are doing actually, better than expected with a disruption of, face-to-face services and that kind of thing. Was there anything that you wanted to add, Dr. Hansen, to that?
No, I mean, one other kind of interesting outcome is that all of us are getting more used to telemedicine. I've actually been doing it for about 10 years in different settings. And, it can be a convenience thing. You can get a corporate person who can have the appointment in their office. You don't have to do the commute. So it's not just, for instance, for rural, but it can be, we're all learning now that it can be used in about any setting. I think I had about 5 appointments this last week where people were sitting in their cars and, stepped out of their job and they're sitting in their cars or something. So, no, you've got it covered.
Okay, let's go ahead and move to this first slide.
Yeah. As you're looking at this, I want to just talk about co-occurring issues in general. This is a little fuzzy, I apologize. It talks about alcohol, specifically alcohol use disorder and mental health. If you look at about the 4th to the last column, it basically gives the numbers for all of the ethnicities that they're measuring here. So this is alcohol plus some of these other disorders. So the first one says any depression, and if you look across to the 4th to last column, so depression in 35.8% of alcohol disorder, and this study was, I believe, in 2012 through SAMHSA. If you want to look at any anxiety disorder, about the 5th item down, and look over, it's 39.6% of those folks. And at the very bottom, any mental health disorder together with alcohol, it's 53%. So about half of folks with alcohol disorder have a significant mental health disorder. So that's one statistic. When you talk about, many of you probably know this, but if you talk about true co-occurring, then classically, you're talking about two distinct disorders. One did not cause the other. They both are separate animals. And so this nomenclature carries that implication. The word concomitant is used. In practicality, a lot of us, we don't really know when we see someone whether they're two separate illnesses or whether one is causing the other. Officially, those would be called, for instance, alcohol-induced anxiety or anxiety-induced alcohol misuse. A lot of times when you first see somebody, of course, you're not going to how that pans out. It does make a difference, though. A couple of, certainly in therapy, it's helpful to know if you're dealing with somebody whose primary disorder is major depression, bipolar disorder, PTSD, and who are secondarily abusing a substance, or vice versa. And there are some clues, and some of you, I'm sure, are familiar with these. But there are some clues as to how to sort out whether it's co-occurring or whether one is causing the other or feeding into each other in some major way. One is obviously chronology. When did you start with your substance use? I'm surprised how many people who kind of assume initially that their depression is because they've got such awful situations going on related to their substance abuse. Then they tell you that the depression started in junior high school, and they paint a pretty clear picture of a major depressive episode well before they started with any substances. So that's one hint, is just looking back and seeing what came first. Another, of course, is treatment, response to treatment. Sometimes, if you're treating the alcohol, you think that the alcohol is causing the depression. You treat the alcohol, the depression doesn't go away, so then you've got an idea about depression being primary. Another is genetics, of course. If I'm sitting there wondering, and I'm on the fence about what's causing what, and then I ask, and they say they've got, half of their primary relatives have had major depressive disorders, and a couple of them have been in the hospital, and or somebody's got a bipolar disorder, something quite genetic like that, or a panic disorder, some things that are very strong genetic components, then you have another clue. So then you at least know, you have a fairly good idea of what's coming first. And of course that all plays into treatment. Sometimes we wonder, we're excited to get into some specific scenarios with you. So we want to get to that here in a bit and talk about some actual specific situations like personality disorders and such. But generally speaking, and I know a lot of you have had experience with this, but you get to listen to us today. So I apologize if I'm telling you some things that all of you that you know, but so for instance, right now I consult with some residential programs, and someone will come in, and of course there's opioid use disorder. There's also major depressive disorder symptoms, generalized anxiety disorder symptoms, and that's pretty common fare, unfortunately. So at first, you may not know which came first, if it's co-occurring. So part of what I end up doing is basically, treating the more acute things first. Obviously, if the person's in withdrawal, you have to focus on that first. And then let's say they're trying to, you get a report from the therapist that they're not functioning in the group because of manic symptoms. Well, you better treat that before. You're not going to get very far with the substance abuse treatment until you get that a little bit under control. And then sometimes it's more of the substance abuse. They're having such strong cravings that you can't really get much else done until you address that. So a lot of it has to do with acuity. It's kind of like in an emergency room. You just kind of have to triage which symptoms you want to target first, both medically and therapeutically, and knock one of them out at a time. In the outpatient setting, one advantage of the outpatient setting, I think, is that you can be a little bit more methodical about how you address these different topics, these different issues that a person might have. Now, for instance, if a person lands in an emergency room and needs to have detox and they've got troubles with alcohol and they've been overusing their benzodiazepine somewhat, but you also know that they have severe anxiety disorders, maybe PTSD, social phobia, but they're in a detox hospital, and so you basically, between y'all and the doctor, you detox them off of everything. You do it all at once. The alcohol, the benzo, there might even be an opiate there. Get it all cleaned out, and then we get to work on how to re-equilibrate after detox and through the rest of continuing treatment. In an outpatient setting, you might opt to do it that in a similar way, but and we do some detox in our office. Actually, do a fair amount of detox. So we wouldn't take someone that was detoxing fully off of alcohol, a benzo, and an opiate, but what is sometimes very reasonable and humane and therapeutic is to detox the alcohol. Let's say they've got alcohol and benzos, so detox the alcohol and then take a month or two to taper off the benzo. Part of the reason for that, as many of you may know, is that detoxing off of the benzo isn't just a medical procedure. You're taking somebody's anxiety medication away. And so there's an awful lot of rebound anxiety that comes along with coming off of benzos. So doing it more slowly is often a therapeutically better option. Not always, but sometimes. So if you want to go to the next, there are a lot of reasons to try to focus on co-occurring disorders. Here are some complications, some things that come along with co-occurring disorders. The one I was paying attention to in particular was the suicide attempts. Again, if you look over to the fourth to the last column where it's all ethnicities, you look down to the history of suicide attempts. On co-occurring, it's 22.6%. So, and that's going to, if you look at other statistics, you're going to find, of course, that that's higher than just substance abuse or just mental health disorders. So there's at least an additive effect there. As you can imagine, if you're a poor soul who lands in a residential program that is really good at the substance abuse, but not quite as strong with the mental health treatment. You know, then it's going to slow down progress in some ways. And vice versa, if it's a mental health program that's not so strong on the substance abuse. Well, we can't all be experts at all of this, but part of the point of this kind of a discussion is to just bring awareness to it and help us all with our training and our staffing. And what I always try to encourage the residential programs that I consult at is simply, know your limitations. If you're only staffed and trained for a certain level of co-occurring issues, then just be aware of that there may be some people that you may want to refer to a different program rather than trying to take it on yourselves. Outpatient setting, same thing. If you're not everybody is as lucky as I am to have someone like Cliff doing the therapy who's knowledgeable on all these areas. And then you've got, for instance, Suboxone type clinics where the physicians are primary care physicians and they have a fair amount of psychiatry knowledge, but it's somewhat limited. So they just encourage them to refer to a psychiatrist or a psychiatric nurse practitioner for that part of it if it's over their head. All right. So just want to double check. Cliff, you're watching the chats. If anybody has any questions that come up, feel free. Mm-hmm. All right. So we're on the next slide, which talks about general principles. And we've talked about this a little bit. If you read through, for instance, the ASAM criteria that relates to co-occurring disorders, and there's actually a slide later on, and if all goes well, we'll send you all a copy of these notes. If you look at the ASAM criteria, I guess that one thing to keep an eye on is programs sometimes get confused in how they present the type of treatment they do. They may have on their website that they do dual diagnosis or co-occurring. Most programs, in my experience, that still means that their primary, for residential in particular, their primary substance abuse, and they also have some training and background and are able to take a fair amount of folks with psychiatric illnesses. More and more, however, are getting completely dually licensed to take primary substance abuse and primary psychiatric patients. So there are some, but not that many. So you have to ask specifically, of course. Are you licensed separately for primary psychiatric patients in addition to your substance abuse patients? So that's a level. So that's a sort of a level of care question. Obviously, if they're dually diagnosed, there's a somewhat better chance that they need a higher level of care. A lower threshold for increasing intensity of treatment with those folks. We talked about diagnosis already. Collaborative care. I can start discussing this a little bit and then be helpful to have Cliff chime in. Sure. Yeah, we talked about in terms of referring and such. I think these folks can get pretty tricky, and even the most cooperative of clinicians can run into some trouble with cooperating. And we'll talk about this a little bit more later too. But if you've got, ideally, you'll be in a clinic where you've got people that can cover all the bases. But that's an ideal situation. So typically, we need to be prepared to do some referring. Hopefully the trend for the future is more and more of these clinics all being in one location, because we do know that we tend to lose some patients anytime we have to transfer them somewhere. It's kind of a weak link in the continuum of care. Anytime we have to transfer them from hospital to residential, or residential to IOP, outpatient, or from a therapy office to a psychiatrist's office, from a primary care office to a therapist's office, those are all weak links, and people get lost between the cracks. So anything we can do to bring it all under one roof, and at least do a lot of communication. As Cliff was saying, some of that gets a little bit easier when you have online technology. At our office, we do a lot of what we call warm handoffs, meaning if a patient's in seeing me and I'm finished talking with them, then I walk them down to Cliff's office and I sit down with them for a minute, and with their permission, I fill Cliff in a little bit on what's going on and my particular concerns that relate to therapy. Or the other way around, Cliff will bring them into my office and that kind of thing. Cliff, what would you add?
No, I think as far as the collaborative care, I think just having worked in the industry for a while now, and I've had experiences, I worked up at uni, crisis admissions. I've worked in the jails. I've worked outpatient, residential. So I've had a pretty full experience in the industry over the last several years, and I would say what we're learning and understanding and accepting and realizing more and more is that when it comes to co-occurring disorders or comorbidities, that we really do have to collaborate a whole lot more than normal. I think between agencies and from provider to provider, because a lot of times the need is so high, and so we're busy really dealing with the risks and needs of patients, day in, day out. It sometimes gets a little difficult to collaborate in ways that actually optimize the treatment process for those patients and the setting that they're in. And so, one of the things that I think that is really important for us in the work that we're doing at our clinic is, where we have case manager, medical assistant, the therapists, medical providers, even to the front desk staff, that we all not only are engaged with each other as part of the full care team or treatment team, but we also are working with collaborative partners outside of the facility to make sure that folks that we are working with those co-occurring disorders, that their care is optimized. And so that's everyone from family members, pharmacies, PCPs, previous therapists or previous treatment providers. What's been helpful for me is, any clinical collateral that I can obtain. And if I can't obtain it from the agency, then I ask the patient to collect that for themselves. In past times, it's been a little bit of a hurdle because, a lot of folks are, having to do ROIs, and then it could take up to 30 days to get that, that clinical. But in my experience, where we have the collaborative partnerships, we have the clinical collateral, the patient with the co-occurring disorder, actually their treatment, their care actually is optimized. And so I just wanted to really point that out.
Thank you. All right. Should we go on to our scenarios?
Yep.
Do you want to moderate this for us, Cliff?
Yeah, so because we don't have the polling option, which I thought we were going to in this Zoom account, it's in my other Zoom account for my teaching. The cool thing is that we have the function of breakout rooms here, but I don't think we'll be doing any breakout rooms with folks. That's a really cool function with the Zoom app, something that we do in our groups, and that I actually do with my students. But I want you to take a look at this list. And so some of the areas, the special populations in substance use disorder treatment for, co-occurrence is, any one of these items here or any one of these topics. And so I was going to pull, I'm hoping that maybe folks using the chat feature can take a look at these topics and maybe tell us, just with a number, what are you interested in? What stands out to you? What might be applicable in your practice? So first one is the medication assisted treatment, Suboxone in a residential setting. I know that traditionally residential settings in the community have been pretty abstinent, persistent. Medication assisted treatment, even medications like Suboxone, have been traditionally, either discouraged or allowed with special exception and circumstance and with a quick taper. And so that is a, interesting dynamic in a residential setting, the MAT and Suboxone for a COD patient and how that can be beneficial. We get into the personality disorders. Number two, you're thinking about, we've got substance use disorder, mental health disorder, but then we've also got that personality disorder category with, its cluster categories falling into that. And so, with taking into consideration, what does that look like to treat somebody, from an outpatient setting? And in any one of our scenarios, it could be a person coming in for an alcohol detox that has been drinking heavily for the last several weeks or several months with some pretty good significant withdrawal potential, and we get them detoxed from the alcohol over the first few days. They have a ton of anxiety throughout that episode of detox, and we're getting them stabilized, and then they have an onset of depression because of all the shame and the guilt and the humiliation and disappointment. And then as we start to get some stabilization with that, they are starting to then return to old behaviors in lieu of or in place of the alcohol or self-medication. And it could be self-harming behaviors. And so then we may be dealing with, a personality disorder or personality features on top of that. And so what is that, how do we create discussion around that kind of scenario? The number three, major mental health. This would include stuff that would typically be disruptive to treatment or interfere with the attendance and add to the attrition rate. This is anxiety, social anxiety, ADHD, where patients have a hard time focusing, concentrating, are skipping or missing appointments because of the distress the anxiety is causing, or the social anxiety of being around people and in groups. Number four, the benzos, gabapentin, stimulants. Thinking about and having some discussion around, what does it look like for a person that's maybe going through or needing to go through detox, has completed detox, but is still has a previous prescription of one or all of the above, and in what ways do we work within and around all that, especially for those folks that maybe had a meth problem, or where they're even might have been detoxing from the opiates, but maybe still for some reason need a prescription of some type of benzodiazepine, or you're using the benzodiazepine, for an alcohol detox, and then how long do you continue? There's some really good discussion around all that. Number five, medically related complications. So thinking about comorbidities, co-occurring disorders, aside from the mental health and the substance use and even the personality stuff, we're then now getting into or seeing HIV, Hep C, and then even the chronic pain or other medical issues that come along with, the substance use, the mental health, and the personality stuff. Thinking about chronic pain, number 6, when can we or should we begin a medication like Suboxone? Is buprenorphine or Suboxone a medication that can be used in place of opiate, a pattern or history of opiate use or opiate addiction, with maybe even opiate-induced hyperalgesia that can maybe help with chronic pain? A lot of times we get into psychic pain on top of the medical issues and the pain that that is there for a patient with, bone and joint problems, back and neck problems, previous or past surgeries, still needing some managed pain medication. So is there a pain scale for psychic pain in relationship to physical pain? And then how are we working within all that around substance use disorder and mental health problems, and then maybe even personality? So things start to get really complicated. These are scenarios or special populations that I think we see and that we see a lot. Number 8, the polypharmacy or hidden addictions. Thinking about those patients that in some ways are coming into and maybe even stepping down from an inpatient or even residential episode, and how many medications are they on? How many medications do they want to continue on, or how many medications is even medically necessary or appropriate? Thinking about, the FDA recommended number of medications for the central nervous system, which is 3. And a lot of times I'm, printing out interactions reports from jugs.com to have them really review and talk about, with the provider. But are there hidden addictions in all of that? Say we can get a person maybe detoxed or begin a MAT induction with Suboxone for a person that is recovering from a severe opiate addiction or opiate use disorder. And then based on the medications that they still might be on or need to be on, are there any hidden addictions in that? And so how do we deal with that? Number 9, collaboration with therapy and medicine. So between therapy and, between the behavioral health side and the medical side, there's this really important need, especially for these special populations under the umbrella of the co-occurring disorders, for us to really be communicating, working together. I mean, we, between Dr. Hansen and I, we, if we have, 20 patients in and out of the office for that day, typically there's, for most of them, going to be some type of warm handoff, me walking or Dr. Hansen walking the patient to our offices to continue some type of care. And so based on the medication that they're on or the type of therapy that they might be receiving or the perspective or angle that we're looking at their case in, what if we disagree? Then what? What do we do? And then number 10, there's this really interesting new, medical marijuana that's had some really good legislation around it. And so now, we have a dispensary where folks with even a diagnosis of PTSD can have a recommendation from their primary care provider. One of the newest things is that the LCSW can now provide that diagnosis. And so for folks that are in substance use disorder treatment, outpatient, dealing with other mental health problems, what kind of considerations can we make for the medical cannabis that they might be using, or cannabis that they might be using that doesn't have a medical recommend? In what ways are we working around and within, that kind of scenario? So I'm just wondering if you guys might engage in the interactive piece of this CEU and maybe use your chat function to maybe just using a number from the list. What is a topic that you might engage
Yeah, we might not end up being able to get to all these in a bunch of detail, but would like to cover some of them, and we just want to see if you have particular interests. If not, you're stuck with what we think is interesting. Well, there we go. There we go.
Got 7, 7, and 8. The psychic pain, the polypharmacy, the psychic pain.
All right. So we can start with that while numbers keep coming in. Thank you.
Yeah.
Cliff, I'll take a shot at it
Hey.
for starters. Psychic pain, hyperalgesia. So many of us know that opioids were intended to be used for acute pain only and for cancer-related comfort care, pain control. But of course, they're being used more long-term. And of course, that's how a lot of people get into the addictions. The discussion that we end up having with these folks at some point is that they may feel like they're still using it for pain control, but it's been proven now that one of the pharmacologic responses that the brain has to long-term opiates is that it begins to react in a way that actually increases pain. There are various reasons, various causes of that, various theories. The most prominent one has to do with glutamate, changes in glutamate function in the brain. There are some specialized opioid receptors that instead of decreasing pain, they actually cause a sensation of pain. So in other words, not only are we talking about, gee, you've got some tolerance now, but we're talking about these medicines are now causing pain directly. So that's important information to educate patients about that feel like they still need the narcotic for pain control. I can talk about psychic pain. If I get it wrong, Cliff, let me know. Anymore, if you're talking about chronic pain, you shouldn't be talking about, I have a chronic pain diagnosis. It should be considered a chronic pain syndrome. Much like someone with diabetes, it's not just a problem with glucose levels and insulin. It's a way of life. It pervades your diet, your exercise. So psychic pain is on top of the physical pain, obviously. The physical pain and then your emotional response to that pain and the fear that comes with that. If anybody's ever been in an abusive physical relationship, you know that the pain from if you get hit because you're being hit by an abusive partner, you could be hit in that very same fashion with the very same force in the middle of a basketball game, and it feels a lot different. So those are examples of the psychological aspect of pain interpretation in our bodies. Cliff, more about psychic pain?
Yeah, I maybe want to just throw a kind of vignette. I mean, I think sometimes, folks like to hear about actual, case examples. And so without revealing any, personal information, I know that you and I are both working, and have been probably for, the last, 8 or 9 months with a woman that is in her late 40s, and she had a pretty significant addiction to opiates, stemming from what are some pretty, I think, significant medical issues with, bones and joints and fibromyalgia and that kind of stuff. And on top of that, had gotten pretty depressed and uh, got into the alcohol and had done a pretty significant binge on the alcohol, to where she not only needed inpatient detox, but then at the same time had a lot of kind of, alcohol induced suicidal ideation and impulsivity going on. So while she needed inpatient detox, what actually brought her into the hospital, and I believe it was an IHC place, but what brought her in was the suicide attempt. And so after being admitted and being on the floor and being inpatient for, several days, she came out to us. Was stepped down to us for outpatient. And so in the hospital, in the inpatient setting, doctors there at that point in time, because not only had she had all this alcohol stuff going on and the suicidality stuff, and then the history of opiate, but also is one of those patients that we see a lot, especially in crisis and inpatient and hospitalization detox, where she was also using the benzo. She had quite a bit of benzos. And so there was lots of different, important things to consider and things going on that needed a really well-rounded, comprehensive kind of treatment team approach and treatment perspective. So she comes to us for outpatient, and so one of the things is coming to outpatient, she wasn't being prescribed the benzos anymore. She wasn't being prescribed the opiates anymore, and really couldn't drink alcohol anymore. In some ways, because of her inpatient experience, didn't really want to. I think that throughout her crisis experience of going to the hospital, there was maybe a transfer throughout that time because of insurance, which was maybe in her perspective a little bit more traumatizing as well. And then she's got this whole history of trauma and abuse in her life, and so she comes, and so her initial pain scale still, even coming from the hospital and having been switched over to Suboxone, was still like a 9, in some days even a 10. And what we started to learn about her is that wasn't all physical pain. At least 3 or 4 points was psychic pain, and not just the psychic pain from the trauma of the recent experience and the hospitalization and the depression and the suicidality, and the transfer between hospitals, and in some ways the way that she felt she was treated. But this history of addiction, this history of trauma, this history of abuse. And so as we got into the therapy part of it, trying to stabilize her on the Suboxone to help with the chronic pain and get her to a place where she, isn't abusing the opiates and the benzos and even the alcohol anymore. We're getting into, from a trauma-informed treatment plan, we're getting into a trauma-informed approach or therapy approach. And so I realized that in working with her, as she's talking to me through all of her psychic pain, that when we worked on that and got her to process through that and release and relinquish a lot of that emotional pain that she continued to carry with her throughout her life, her pain scale actually went from a 9 to a 6. And so I think one of the important things about this is, one, the collaboration. So I'm talking to Dr. Hansen because potentially she's going into his office and saying, well, I need this and I need this and I need this, and relating it all to the medical issues. And so, Dr. Hansen's really smart. And so I think in a lot of ways can, make some really good determinations and medical decision-making around all that. But for a lot of other providers, especially the new prescribers out there that are new to the field, might, in an unintentional counterproductive way, continue to prescribe medications on top of medications and be right back in the same scenario. So my collaboration or my coordination with Dr. Hansen is, let me work on the psychic pain and you continue to address the medical pain, and let's keep working together. Because if we really focus and see this as a psychic pain issue, not just a medical pain issue, and we can reduce the scalp pain down, by 3 or 4 points, then she's in a really good place. And so for this patient, 8-9 months later, with a few bumps in the road and a few little hurdles, is still able to come into our office with a pain scale of 6, which for her and her conditions, all things considered under the circumstances, is actually right where she should be. Now, thinking about, had we not been able to coordinate or collaborate care in that kind of way, where would her pain scale still be, and how much of it would be medical versus psychic, physical versus psychic pain?
Yes, thank you. Now, there's a question here. Does the type of pain created by the chronic opiate use, this is from Kathy, does the type of pain created by chronic opiate use eventually go away after the patient is off the opiates? Yes, it does. Yes, it does. The psychic and psychological pain may take a little bit longer, and any other sequelae from having been through chronic pain, which is a form of torture. People describe chronic pain as a form of torture. So there's PTSD type symptoms related to being in recovery from chronic pain. But yes, opioid-induced analgesic or hyperalgesia does go away. Those receptors re-equilibrate.
How long do you think that? How long do you think that? Maybe, I mean, I guess it's patient by patient, but maybe on average or typically, we might see that lifting maybe weeks or
Very
months.
complex question, because a lot of people do have underlying physical pain issues that persist, and now you've taken away the strongest medicine to block that. So I would say if there are underlying injuries, they're pretty much gone, and you're really just looking at this phenomenon. Couple months. I'd have to look it up, but that's my sort of my ballpark experience with that. Should we go on to another question?
Yeah, I think the other number that people kind of wanted to hear about was the polypharmacy and the hidden addiction.
Polypharmacy. Yes. Um, so a lot of what I do in my line of work, I have the advantage of working in an addiction specialty clinic. So people can come in with a long list of medications, and I can start help looking at what's reasonable to chip away at. If you're a consulting psychiatrist, that ends up being part of your job. We get that especially with elderly folks who end up getting too many meds stacked on board. We get it with addictions, we get it with pain. We all know that doctors in general are there to try to help people, and so when people come in with a pain complaint, which is the most common reason to go to a doctor, doctors just have this sort of, I guess, potentially codependent need to help them not have the pain or the discomfort. We're supposed to do something, and doing something means putting our pen on a prescription pad. So that's the psychiatrist or the physician's dynamic there. So we do a messy job sometimes of contributing to stacking up meds. And we don't want dissatisfied customers. And one really easy way to dissatisfy a patient is to tell them no to a request for a medication. So it goes a little bit against our grain, and it can be awkward at times, but we have to sometimes be good parents and hold boundaries and tell people no. Just really quickly, I mean, there are various reasons to be concerned about polypharmacy. Obviously, drug interactions and also cumulative effects on the brain and the body. Addictions. With older folks in particular, you can get cognitive effects of medication interactions. You can get falls and broken hips. People end up in nursing homes. So the trick is, in my mind, one is how to approach the patients about it. Another is how to be methodical about what you're doing. And there are ways to do that, and we don't need to get into the details on some of that. I think on the medical end, obviously, you're looking for the meds that are causing the most damage, that have the least objective reason for being there. And you might start inching away that way. For some medications, there's another option that might cover the symptom but has less potential side effects and interactions. For older folks, anything with what we call anticholinergic activity, like antihistamines and some antidepressants, and some blood pressure medicines, and they're touchy about those. You can always, as Cliff mentioned, as a therapist, go on drugs.com. In fact, we'll show you at the end here, we have on our resource sheet, they have a drug interaction program on the website, and you just plug in the name of, say, one or two medications, and it shows you a list of potential interactions between those two medications, starting with anything that might be major and then going down from there. So the addiction piece of that, I always try to be careful about different flavors of addiction, because as some of us know that work in this area, there's true addiction, which by definition means, they're using it and they know it's causing harm and they continue to use it. That's different from dependence, right? Dependence just means that they've developed essentially some tolerance and some withdrawal symptoms. So their body has become physiologically sort of pickled and used to being on it. And then there are people who just feel like they need that medication. So that's what I would call a psychological dependence. You can get that with meds that don't have any true addiction quality to them. If somebody is convinced they need a certain cholesterol medicine, and maybe they don't anymore, but they may still feel like they need it. There are a lot of medicines like that, where they think they need it, and if you take it away, they're going to have some awful effect. Some anxiety medicines are that way too. They don't really need it, but they're pretty convinced they do. So there's a lot of talking to folks. From my perspective, the most important thing to do is to develop trust and to develop a therapeutic alliance, so that they see you as their partner, and you're not going to just start torturing them by pulling away these medicines that some other doc said was very important for them. That goes a long way. And you don't have to do it all at once, unless there's some really obvious, altered level of consciousness or falls or something. Doesn't all, it can be done stepwise. And yes, hidden addictions, absolutely. Hidden psychosomatic issues come up. Cliff, anything else on that?
Yeah, I just want to kind of, I really, in my practice, I've really appreciated that drugs.com interactions report. I think I have found it very helpful. So I don't know how many other people are using that or maybe plan to use it, but it can be really helpful, not just to, to show the patient and educate them, because with the polypharmacy, there is a lot of education. A lot of patients don't really know, or don't really clearly understand or have been educated about not just the risks of the medications, but the interaction risks of a combination of medications, especially, more than 3. And so when we talk about, and it can be helpful for them to share that with their provider or their prescriber too. When we talk about the hidden addictions, and keyword hidden here, because, there is that there is that differentiation between addiction and dependency. Sometimes people, though, think or believe that because they're not using an illicit or street substance, um, as long as they're on polypharmacy, that it's okay. And in some ways, they might just be using the pharmaceutical medications in the same way or similar ways that anybody with illicit or street drugs are. And so I think one of the things that we do well, and Dr. Hansen, I think what we do well is we use the therapeutic drug, urine testing tool, the presumptive test, the cup test, which, is, I think, what we have 14 panels or something like that. And so we use it as a therapeutic tool. We, over the long term, while they're in and out of our clinic, are kind of measuring, what might kind of be coming up, in their urine test. And so when we see other things coming up, especially, any pharmaceutical medications, we're having those kinds of conversations around, combination risks, and that kind of thing. And then, printing out the drugs.com interactions report. With the polypharmacy, I think that, what I'm seeing in my practice and in my experience, is a lot of, and this might go up to number 4, but is a lot of the, the opioid epidemic is something that everybody's clearly aware of. And I think we've made some progress in that area. But then we've got the gabapentin, alongside, the sleeping medications, the narcotic sleeping medications. And I've seen folks have a pretty, not just dependence, but a pretty significant addiction to these kinds of things as well, in combination with each other. So you have a patient that might, be taking, 1,000, 2,000, 3,000 milligrams of gabapentin a day. And then on top of that, taking more than prescribed sleep medication. And these are the kinds of issues that they come in with. And then on, when we talk about the comorbidity or the co-occurring stuff, there might be really good reasons why they're using those medications in that kind of way, for then the anxiety or the insomnia. And underlying that, there might be really good reason for that, as far as, the trauma, or any other kind of mood disorder that they might be dealing with. And so initially they might have come in, to us with a true need to, detox or start medication-assisted treatment for an opiate use disorder. So I just kind of want to point out, because while we're talking about special populations and the COD patient in a substance use disorder treatment setting, outpatient, I just kind of wanted to point out, that's some of what I see, and then some of the things that we are doing to kind of, help those kinds of patients through that.
Good. Well, I think we have time to cover one more, and then we've got some sort of wrap-up things we wanted to show you. Cliff, you see the numbers there.
Yeah, it looks like number 3 and 4, which is, I think you have a lot of really great insight with, the major mental health and then the benzos, gabapentin stimulants, the anxiety kind of stuff, thinking about, prescribing orders for those kinds of things as
Sure.
a COD patient in an SUD treatment center.
Okay. 3 and 4.
Yeah.
More or less. Okay. Yeah, this is kind of the meat of what you think of when you think of co-occurring disorders, mental health and substance abuse. And of course, you could talk about all kinds of different, and co-occurring officially includes both what we used to call axis 1 and axis 2. So the personality disorders is also considered co-occurring with a substance abuse issue. A couple things that just are kind of interesting, and I don't know that we need to spend a whole lot of time on this right now, but in a residential setting, for instance, you've got some potential tug of war between prescribing and doing therapy, and between prescribing and the abstinence challenge. Now I've I've had a fair amount of experience with these things, and I've had a lot of exposure to. I enjoy 12-step fellowship exposure. I understand that the most meaningful recovery from addiction includes, in a sense, a spiritual component, a large spiritual component, and perhaps that's the most important component, meaning, an improvement in quality of life, an improvement in purpose of life. What I like to talk to patients about when they first come into a recovery program is just being sober is very boring. There's not much exciting about just stopping a drug. So what's exciting about treatment to me is the growth, the personal growth and the family growth and the personal strength. So it's a real issue. You get a prescriber in there like myself who threatens to block a bunch of symptoms or affect a bunch of symptoms with medications, and it's going to potentially get in the way of therapy and spiritual growth, and it's going to take away, you're going to give somebody Suboxone, and it's going to take away their incentive and sort of the emotional drive and sort of the discomfort that needs to be there to make a change. Those are all very real issues. So generally speaking, I try to address it like this. I try to interact with the team. Supposedly the doctor has the final word with things, but I don't think that works very well in these kinds of settings. I think it's a team approach. And you do, if somebody's got a major mental health issue, it's going to be impeding their progress. It needs to be treated medically. If somebody has a genetic major depression, it's unethical not to treat it. There are, and people can actually, statistics definitely are supportive of treating medically those mental health disorders that come up during substance abuse, and it makes it a lot easier for these people to become and stay sober if you're treating their co-occurring mental health disorders. The tricky issues become, for instance, with if you're looking at potentially a mental health disorder that normally is best treated by a controlled substance. That's why I've got anxiety and ADHD listed there, because you know, we all know that by far the best treatment for someone with nasty ADHD is a stimulant, and nothing else works very well. So you get into those discussions, and same with anxiety. I mean, nothing works better than a benzo for anxiety. So what do you do with that? Well, with benzos, there's a lot of reasons not to use them in a substance use setting. I've got some articles in the resources at the bottom that address some of these things. I would have to say that it's not a never say never. I think I have had situations in a co-occurring residential program where the person, it was just cruel to not treat their level of anxiety with a benzo, even though they were in the residential program for meth, for instance. It becomes tricky because you're sitting there in an environment where, you know, you have to control the milieu, and then the other clients learn that somebody's on a benzo. So it's I wouldn't recommend it for the most part, but it can be done, and once in a while probably should be, but it's tricky. ADHD treatment is a little bit different. I think the data shows that once in a while it makes sense to treat some poor soul that's got nasty ADHD who's trying to learn in the residential program or in the outpatient IOP, but they can't grasp the recovery principles because they can't track what's going on. So once in a while, probably more often than a benzo, I'll prescribe Adderall to someone in a substance abuse program. Again, it's reasonable to first try, if you're doing medicines, it's worth trying, well, first therapies, then it's worth, of course, there's Strattera, which does okay, and guanfacine and clonidine and other meds that can be used. But just some interesting topics. Kind of touchy, but I encourage everybody to just look at the research. Same with Suboxone in residential. For people with recurrent opioid issues that have had scary overdoses and recurrences in multiple treatment settings, the data shows now, you know, programs really should be considering continuing MAT type treatment, Suboxones, buprenorphines, and things like that in a residential setting for some of those people. I'm not going to try to dictate what people do. I'm just saying, please read the outcome-based literature before you design your program. So that's that.
We had a question come through, just wanting to know the opinion on ketamine, microdosing, psilocybin. Let me go first, and then I'll let you go, Dr. Hansen. I just want to say, you know, to that topic, it's not something that I'm actually really educated on. It's not a focus in my specialty or expertise. I do know that from the patients that I have worked with, that have, you know, use that type of medicine for the appropriate reasons and through a provider licensed to provide that. It's kind of half and half. I mean, some people it works for, some people it doesn't. The kind of shared experience between all the patients that I've asked about this is there are some temporary benefits, keyword temporary. And so that seems to be, you know, one of my takeaways as I listen to people and what their experience is that for a lot of folks, the shared experience is that's more temporary than permanent. But again, I mean, that's just patient experience and not research and literature, but that's my only take or opinion on it.
Cool. Yeah, good question. There's a lot of this going to be coming out in the next while. And I think it's a good thing that it's coming out because there's not been much on the medical end that's been terribly new and helpful for particularly for depression for, since the 60s. Um, uh, my main concern is just the prescribers hopefully are aware that these people aren't walking in with just depression. Some of them are walking in with serious substance abuse issues, traumas, dissociations. Do you want to give ketamine to somebody who has PTSD and already a tendency to dissociate? I mean, it's just they're just same with marijuana. I mean, it's not a simple chemical, so it may benefit certain people, but may be harmful for other people. So. Just hope that people are thorough when they're evaluating these people.
I think one of the principles in the way that we do addiction medicine in our treatment and our treatment approach is that we go back to SAMHSA's guiding principles of recovery for both substance use and mental health, and we recognize that not one size doesn't fit all, and that there are many pathways for each individual patient, and that's going to look different from one to the next. I think that's a principle that is in some ways necessary and required in a substance use disorder treatment setting for folks that have co-occurring disorders or comorbidities or those special populations that we are talking about now.
Good point. Well, let's pop through the rest of this so these folks can get on to lunch or whatever else.
It's 128. We were going to talk about, how to measure and follow the patient progress over time, keyword over time, talking about how to adjust for slips, relapses, and then, what our contingency management, ways of doing things or guidance is. We were going to really talk about being ASAM driven for this type of population or for this type of patient, and letting people know that there is new risk rating for ASAM. It's a 0 to 4, something that we do with our patients every week because of the comorbidities or the co-occurrences. Every Monday, every week, you have to, for this type of population, be assessing at least weekly, if not more than that, in order to improvise or adapt treatment planning or therapeutic approaches or even medication approaches. We were going to go through the trauma-informed treatment planning process that I really wanted to take folks through, which is, I think, really important for this population. And then we had some references and resources. We were going to ask people to make sure that you email Spencer with your attendance confirmation. I was going to provide people the trauma-informed treatment planning guide that we have for this population. If you want that, will you please email me so I can share that with you? Again, my email address is cliff@altiumhealth.com. And then we were going to do a survey, but because this Zoom doesn't have the function for polling, happy to receive any feedback. If you have any feedback or input for Spencer in terms of this CEU, if there's anything else that you would like us back for. Again, this is such a enormous topic. It really could have at least 2 parts, and so we're happy to come back and do part 2 of maybe even a 3 or 4 part series,
mini series.
Yeah. So does anybody have any last questions? Dr. Hansen, do you have any last words? Happy to start wrapping things up and get people going with, thank you all. For those of you, a lot of you are on the front lines in the hospitals. I appreciate the work that you're doing. Please stay safe. Just really appreciate the work that you're doing. If you are still in a hospital setting or a crisis setting.
Well, thanks for joining, and thank you so much for your service.
Thank you.
Okay.
All right, we will sign out. Take care,
All right.
folks.
Have a good one. Thanks, everyone.